Greetings and welcome. My name is Annette. I'm a staff anesthesiologist at Toronto General Hospital, Toronto, Canada. This session is on aortic insufficiency and the role of TEE in surgical decision-making. The objectives of today's session are to 1. Describe and identify the main mechanisms of valve lesions associated with aortic insufficiency. 2. Discuss the assessment of AI. 3. Discuss the role of 3D TEE in imaging the aortic valve. 4. Show using cases the impact of intraoperative echocardiographic assessment on surgical decision-making. I have no conflict of interest. While we frequently think of the aortic valve as functioning independently, it is actually an integral component of the aortic root. The aortic root is not a simple two-dimensional line drawing, but is a complex, dynamic, three-dimensional structure. The aortic root forms the transition from the muscular left ventricle to the elastic aorta. It extends from the base of the aortic valve cusps to the sinotubular junction. It comprises the aortic valve, three sinuses of Valsalva, sinotubular junction, and proximal portion of the ascending aorta. For the relevance of this talk, I will just highlight a few points. The aortic root is dynamic, changing dimensions and position throughout the cardiac cycle. The annulus dilates mostly around the fibrous support, with asymmetrical dilatation of the non-coronary sinus. The sinuses of Valsalva are important to aortic valve function by reducing stress of the aortic valve cusps. The geometry of the aortic root in part determines the dimensions of the aortic valve to ensure adequate aortic valve function. The aortic annulus is 15% smaller than the sinotubular junction. In addition, the aortic root height is 30% of the annulus diameter. Absolute cusp size variations are the rule. Cusp free edge margin is approximately equal to the diameter of the annulus. The base of the cusp is roughly equal to 1.5 times the length of the cusp's free margin. We are all familiar with the standard TEE views to image the aortic valve, including the mid-esophageal aortic valve short axis, mid-esophageal aortic valve long axis, transgastric long axis, and deep transgastric views for spectral Doppler alignment. The advent of 3D TEE has permitted some detailed visualization of some aortic valve and root pathologies. Shown here is a 3D live mid-esophageal aortic valve long axis and short axis views compared with standard 2D images. 3D color can also be used to determine the origin of AI jets. The base of the heart, including the intimate relations of anatomic structures, can be seen in this full volume. By convention, according to 2012 ASC guidelines, the 3D aortic valve images are displayed with the right coronary cusp at 6 o'clock. This is similar to what is obtained with a 3D live acquisition of the mid-esophageal aortic valve short axis view. The surgeon's perspective is rotated counterclockwise 45 degrees to place the right coronary cusp at 3 o'clock. Much like there is an option to create mitral valve models, there is an option to create dynamic aortic valve models using the EasyValve software. This semi-automated software uses a 3D aortic valve dataset. Specific aortic valve and leaflet measurements can be generated. Unfortunately, in pathology, the aortic valve becomes thinner and difficult to image with 3D, making the models prone to error. So what do we look for when examining the aortic valve for pathology? First, we can look for the structure, including the number, mobility, presence of calcification or masses, and root geometry. Second, we can look at function in terms of color Doppler for aortic insufficiency or aortic stenosis, and spectral Doppler for pressure gradients. For structure, an important determination is the number of aortic valve cusps. This is assessed during systole from the midesophageal aortic valve short axis views, looking at the shape of the orifice and the presence or absence of commissures. A normal tricuspid valve has a triangular shaped orifice. A bicuspid valve has an oval shaped, a unicuspid valve a circular shape, and a quadricuspid valve a square shaped orifice. Note, there is often abnormal motion of the cusps in the aortic valve long axis view as well. Bell-Currie from Belgium proposed a functional classification of aortic insufficiency analogous to Carpentier's for the mitral valve. It has some merit in combining transesophageal and surgical findings to determine valve sparing suitability. As shown here, there are 3 types based on cusp motion. Type 1 includes normal cusp mobility with central aortic insufficiency and consists of 4 subtypes related to root or ascending aortic dilatation or cusp fenestration. Type 2 includes excessive cusp mobility with eccentric AI, usually as a result of cusp prolapse or flail. Type 3 includes restricted cusp mobility with eccentric AI from commissural fusion or calcification. Examples of type 1 pathology are shown in these stills. Type 1 typically would be an ascending aortic aneurysm with or without AI. Type 1b, a root aneurysm, includes dilatation of the sinuses and STJ with central aortic insufficiency. Type 1c, dilatation of the entire root from the annulus to ascending aorta. Type 1d may include root dilatation with fenestration or perforation. Of note, annular dilatation in the absence of STJ dilatation does not result in AI, but reduces commissural height. Thus, isolated STJ dilatation may result in AI. Examples of type 2 cusp prolapse can be further subdivided into flail cusp with eversion of the cusp tip towards the left ventricular outflow tract. Whole prolapse includes the entire cusp below the annular plane with the tip pointing towards the aorta. Partial prolapse includes only part of the aortic cusp below the annular plane. Fenestration includes degeneration of the cusp edges. It is important to identify these cusp pathologies in addition to root dilatation to ensure an adequate repair and identify residual causes of AI post-cardiopulmonary bypass. It is useful to consider etiology and mechanisms of AI separately. Etiology is the cause of the disease. there are many underlying causes for aortic insufficiency. These causes can be broadly categorized as those involving the cusps or secondarily from diseases affecting the aortic root or ascending aorta. Cusp pathology includes those listed, while aortic pathology can be from aortic dilatation or aneurysm formation, and loss of commissural support as the result of trauma or dissection. Whether a novice or experienced echocardiographer, there are important technical considerations to keep in mind when examining the aortic root. Should you measure the root in systole or diastole? There is a difference in size as the root increases in size by about 16% during systole. The convention is to measure the aortic root in diastole so that the measurements match other imaging standards such as CT and MRI. The annulus, however, should be measured in systole. It is important to have as symmetrical alignment as possible and optimal gain. A high gain thickens the aortic walls. There is some variation in body size and age, and root measurements as shown in the Framingham transthoracic data. However, most follow the absolute measurements as mentioned in the guidelines. Current guidelines grading AI severity use a multimodal approach that involves integrating qualitative, semi-quantitative, and quantitative data. The most common techniques include measuring pressure half-time, vena contracta width, jet velocity divided by the left ventricular outflow tract width, and descending aorta flow reversal. Quantitative measures are less often performed, but can be attempted. The grading of AI is complicated by technical and hemodynamic factors. Technical factors include using an appropriate Nyquist limit, assessing jet type for eccentricity and multiple jets, and spectral Doppler for alignment. Hemodynamic limitations include the pressure difference, which is load dependent, and the duration, which varies. There is a difference in hemodynamic consequences of acute and chronic AI. The final grading can be quite complicated with the presence of concordant and some discordant information. But who really has the time for all of this in the operating room? The newest guidelines for the use of TEE to assist in surgical decision-making in the operating room were published in 2020. The goals for pre- and post-repair assessment are listed here. Intraoperative 2D and 3D TEE can 1. Define the mechanism of AI, 2. Provide information to guide the repair, 3. Interrogate the result, and 4. Determine the predictors of durability. In addition to the 2D and color flow Doppler assessment of the aortic valve as described above, the pre-aortic valve TEE focuses on aortic root measurements, aortic cusp motion, the level of cusp coaptation, coaptation height, and analysis of the AI jet direction. Simultaneous multiplane imaging allows scanning of the cusp edge and more precise localization of lesions, particularly useful in differentiating between non-coronary and left coronary pathology. Current 2020 ACC/AHA guidelines recommend aortic valve intervention for symptomatic patients with left ventricular systolic dilatation and impaired function. The latter is a key determinant of survival and functional status after aortic valve intervention. In asymptomatic patients or those with moderate disease, the decision to intervene considers several factors, including aortic valve anatomy, aortic root size and shape, regurgitation severity, and other comorbidities. Management of bicuspid aortic valve disease differs in that there is consideration of aortic size as indicated here. What are the surgical options in aortic insufficiencies? This includes aortic valve replacement, Bentall procedure with replacement of the aortic valve and aorta, valve-sparing route with or without aortic valve repair, and the Ross procedure, which exchanges the native pulmonary valve into the aortic position and replaces the pulmonary valve with a homograft. For optimal results, the latter three options should be performed at a center of surgical excellence. Sparing procedures use a Dacron graft to replace the diseased aorta. This may involve just replacing the ascending aorta, replacing the ascending aorta and a single sinus, using a reimplantation technique, or a remodeling technique. Speaking of valve-sparing procedures, I do work at a center of surgical excellence with two of the originators of the valve-sparing root reimplantation technique, Dr. Tyrone David and Dr. Chris Findell. They published their seminal work in 1992. For disease involving the aortic root, the aortic root is excised, and either a remodeling or reimplantation technique is used to reimplant the native aortic valve. The reimplantation technique favored by our group involves using a straight Dacron graft into which the aortic valve is implanted. This involves 3 suture lines and is a reproducible and durable technique, though no sinuses are created. The remodeling technique uses a scalloped Dacron graft and involves 2 suture lines, creating neosinuses. In general, then, patients who are referred for this procedure may be symptomatic or asymptomatic with AI and have root dilatation. Patients less than 70 years old are offered the procedure in the settings of acute type A dissection, an aneurysm greater than 48 millimeters, and aortopathy greater than 45 millimeters. Additional indications in patients less than 60 years old include patients with bicuspid aortic valve and an aortopathy greater than 45 millimeters, and severe AI and a root greater than 40 millimeters. Contraindications are listed here and include the obvious problems of lack of surgical expertise and cusp pathology. Other specific patient problems include poor left ventricular function, concurrent coronary artery disease, and bicuspid aortic valve in the older patient group. In many cases, despite good TEE imaging, the final decision to perform a valve-sparing root procedure relies on the quality of the cusps. As shown here, poor quality cusps are those that have perforations, fenestrations, rolled up cusp edges, or calcification. This is a great paper that outlines specific measurements the surgeon wants to spare the valve. These include the aortic annulus measured hinge point to hinge point at end systole, which should be less than 25 millimeters. The effective height is the distance from the annulus to cusp coaptation and should be less than 9 millimeters. The coaptation height is the length of the cusp coaptation, which should be greater than 5 millimeters. Geometric height or length of individual cusps which should be greater than 16 millimeters. So enough about the theory. Let's get to some cases. The first is an 80-year-old female. She is asymptomatic and has comorbidities of hypertension. Transthoracic echo shows an aortic aneurysm with aortic insufficiency. A CT scan shows an aortic aneurysm of the ascending aorta and proximal arch. What two abnormalities are present in this mid-esophageal aortic valve long axis view? It is obvious the patient has a dilated ascending aorta. What is less obvious is the abnormal position of the coronary artery. Color Doppler at a Nyquist of 58 centimeters per second shows the presence of AI in the mid-esophageal aortic valve long axis and mid-esophageal aortic valve short axis views, and helps to establish the central location of the aortic insufficiency. The simultaneous 2D image shows thickened aortic cusps edges and central malcoaptation. Let us look a bit closer at the mechanism of AI in this patient. The mid-esophageal aortic valve long axis view shows the aneurysm involving the ascending aorta. There is good cusp coaptation. Measurements of the appropriate segments of the ascending aorta are shown. Measurements of the left ventricular outflow tract and aortic annulus occurs in systole using an inner edge to inner edge technique. Measurement of the aortic route is in diastole using an inner edge to inner edge technique. The sinuses are measured at the end of the coaptation line and the STJ where the aorta begins. Finally, the ascending aorta is measured at the level of the right pulmonary artery, perpendicular to the walls of the aorta. In this patient, the aorta is dilated from the STJ through to the ascending aorta. This patient represents a type 1A pathology, which involves dilatation of the sinotubular junction and ascending aorta. Next, how significant is the AI? Is it mild, moderate, or severe? Most of us would eyeball this and guess this was maybe moderate AI. Common measurements of AI are shown here, including the vena contracta width measuring 7 millimeters, the jet height to LVOT ratio measuring 31%, the pressure half time of 405 milliseconds, and no descending aorta reversal of flow. All these findings suggest moderate aortic insufficiency. Quantitative measures are obtained using the PISA method. In this case, the transgastric views are used to align both color Doppler and spectral Doppler. The baseline is then shifted to obtain the largest PISA shell, which is measured. Tracing the previous AI spectral Doppler trace automatically yields information about EROA and regurgitant volumes. In this patient, these values suggest moderate AI with an EROA of 0.18 centimeters squared and a regurgitant volume of 46 cc's. The ascending aorta and STJ are dilated with moderate AI from central malcoaptation. The surgeon must address the ascending aorta dilatation and reduce the amount of AI. Options are to just replace the diseased aortic segment, the entire root, replace the valve, replace the root, and ascending aorta. As the aortic valve was structurally intact, the surgeon chose to just replace the ascending aorta with a Dacron graft. Shown here are the key findings in the post-cardiopulmonary bypass TEE. The aortic valve long-axis view shows the Dacron graft replacing the ascending aorta and the native aortic valve with good function. The aortic valve short-axis view shows mild aortic insufficiency. Case 2 is a 62-year-old male who is asymptomatic. He has comorbidities of hypertension, superior ventricular tachycardia, obstructive sleep apnea. He is a current smoker and type 2 diabetic. His transthoracic echo showed a dilated aorta and aortic insufficiency with a left ventricular internal diameter of 63 millimeters. His angiogram showed a 50% left anterior descending artery lesion. The mid-esophageal aortic valve long-axis view shows an obvious aneurysm involving the aortic root. The probe is manipulated to 167 degrees to make the aorta appear horizontal, though this may not always be possible. Focusing on the aortic root shows distorted architecture with minimal cusp coaptation. Color Doppler at a Nyquist of 58 centimeters per second shows a central jet of AI in the mid-esophageal aortic valve long-axis and short-axis views. The mid-esophageal aortic valve short-axis view shows large cusps with thinned edges and central malcoaptation. Again, let us look a bit closer to identify the mechanism of aortic insufficiency. The mid-esophageal aortic valve long-axis view shows the aneurysm involving the aortic root. Measurements of the appropriate segments of the ascending aorta are shown during different parts of the cardiac cycle. The annulus measures 2.4 centimeters in systole, while diastolic measures show dilated sinuses at 5.2 centimeters, sinotubular junction at 5.0 centimeters, and ascending aorta at 4.2 centimeters. In this patient, there is dilatation of the aortic root, sinotubular junction, and ascending aorta with sparing of the aortic annulus. This represents a type 1B mechanism according to the El-Khoury classification. How significant is the AI? Is it mild, moderate, or severe? I would say that with this pathology, the amount of aortic insufficiency is irrelevant, as there is a structural abnormality of the aortic root that requires addressing. In fact, some patients present having no aortic insufficiency. Most of us would eyeball this and guess that this was maybe mild to moderate AI. Common measures of AI are shown here, including the vena contracta width measuring 3.2 millimeters, jet height to LVOT ratio measuring 28%, pressure half time of 561, and intermediate descending aorta reversal. This confounding data suggests mild to moderate aortic insufficiency. Quantitative measures are obtained using the PISA method. In this case, the transgastric views are used to align both color Doppler and spectral Doppler. The baseline is then shifted to obtain the largest PISA shell, which is measured. Tracing the previous AI spectral trace yields information to calculate the EROA and regurgitant volumes. In these patients, these values suggest moderate AI, with an EROA of 0.13 centimeters squared and a regurgitant volume of 24 milliliters. The surgeon has a few choices in this patient: a Bentall, including replacement of the aortic valve and aorta, an aorta replacement, a valve-sparing root, a simple aortic valve replacement, or a Ross procedure. Not surprisingly, at TGH, we see many patients presenting with this pathology who undergo a valve-sparing procedure. This video shows the entire aortic wall is removed, only leaving the crown-shaped valve and commissures, which will be sutured inside the Dacron graft, as shown here. The water test is perfect, and the coronary arteries are reimplanted into the Dacron graft. The proximal portion is anastomosed. Shown here are the key findings in the post-bypass echo. The aortic valve long-axis view shows the valve-sparing route with native aortic valve and good function. The aortic valve short-axis view shows no AI. Specific assessment post-valve sparing involves recognizing the root is thickened. Assessment of cusp coaptation is critical. Ideally, the cusp should coapt above the annulus without any portion of the cusp prolapsing below the annular plane. The highest point of coaptation is in the mid-sinuses. Effective cusp height is the difference between the highest coaptation point and the annulus, which should be at least 9 millimeters. Coaptation length should be at least 5 millimeters. There should be no more than mild aortic insufficiency. Left ventricular function should be assessed, and if regional wall motion abnormalities are present, coronary blood flow should be examined. Case 3 is a 31-year-old male who is asymptomatic with aortic insufficiency and a mildly dilated left ventricle. Based on these views, what is the patient's pathology? This patient has a classic bicuspid aortic valve. The mid-esophageal long-axis views show prolapse of both cusps, with more of the anterior cusp, resulting in posterior directed aortic insufficiency. Just a quick word about bicuspid aortic valve. A bicuspid aortic valve has two cusps and is classified by the Sievers classification based on the number of raphe, of which there are 3 types: 0, 1, and 2. The commonest is type 1, with a single raphe and fusion of the cusps, creating 3 subtypes: left-right fusion 71%, right non-fusion 15%, and non-left fusion 3%. This is a great paper by Michelini et al. That well summarizes the echocardiographic assessment of a bicuspid aortic valve. It is well worth the read. They suggest identifying these structural features: cusp fusion, presence of raphe, early valvular degeneration, complete fusion versus form frustra, true sinuses and 2 symmetric cusps, asymmetry of cusps and sinuses, differentiating bicuspid from unicuspid, identifying dilated segments, and root phenotype. In addition, the assessment for valve repair includes identifying the mechanism of AI and cusp prolapse, valve calcification, annular measurement, non-fused cusp commissural angle, the effective height, and asymmetry of sinus dilatation. The non-commissural angle is measured as shown here. Shown here are the mid-esophageal aortic valve short-axis views of examples of type 0 bicuspid aortic valve, type 1 with fusion of the right and left cusps, and type 1 with fusion of the non and right cusps. Favorable indicators for aortic valve sparing repair include correcting the mechanism of AI, such as annular dilatation and cusp prolapse, a commissural orientation of greater than 160 degrees, mild degree of raphe calcification, geometric cusp height measured intraoperatively from the sinus nadir to the cusp tip of greater than 20 millimeters, and if annular dilatation is present, correction by annuloplasty. The main aim is to optimize commissural orientation as close to 180 degrees as possible, as in the symmetric Sievers type 0 bicuspid aortic valve, and to increase the geometric cusp height in an attempt to optimize coaptation. The longevity of the repair in bicuspid aortic valve is good at reference centers. The mechanism of AI in this patient is a bicuspid aortic valve type 1 with right and left cusp fusion, prolapse of the anterior cusp with eccentric posterior AI. The aortic valve annulus is dilated at 3.18 centimeters. The commissural angle is 170 degrees with a normal ascending aorta of 2.5 centimeters. The geometric height is an intraoperative measurement performed by the surgeon using special calipers. In this case, the surgeon performs a valve-sparing route procedure with post-pump assessment that includes the anatomy in terms of coaptation height and length, effective height, and residual prolapse. Here, the coaptation height is 1 centimeter and the effective height is 1.3 centimeters, both above acceptable limits. As well, the function is determined by both color Doppler to assess for aortic insufficiency and spectral Doppler to rule out any gradient through the valve. Here is the mid-esophageal aortic valve short axis views and transgastric views, which show a good result. The modest gradient likely reflects a hyperdynamic left ventricle. Case 4 is another patient with similar pathology. It is a bit more challenging to sort out the number of cusps in 2D, as there is significant prolapse in one of the cusps, as shown in the mid-esophageal aortic valve long axis view. The arrow also indicates there is a flail portion of the valve. "3D imaging confirms that this is a bicuspid aortic valve type 1 with fusion of the right and left cusps and presence of a raphe indicated by the arrow. Color Doppler shows there is severe eccentric anterior directed AI and a second jet associated with the flail portion, suggestive of a perforation. The mechanism of AI is a bicuspid aortic valve with prolapse of the posterior cusp and eccentric anteriorly directed AI and likely a perforation. The aortic valve annulus is dilated at 2.83 centimeters, with the remainder of the aortic root and ascending aorta not dilated. To address this patient's pathology, the surgeon elected to perform a Ross procedure with implantation of the native pulmonic valve in the aortic position. Assessment involves similar parameters for structure and function. Case 5 is a patient with 3 aortic valve cusps, but even in short axis, there is evidence of an abnormality. This is quite prominent in the mid-esophageal aortic valve long axis view as a prolapsed right coronary cusp. Note in diastole, with the valve closed, there is a double shadow from the prolapsing cusp. In systole, there is redundant cusp tissue. The mid-esophageal aortic valve long axis and short axis views confirm the presence of severe aortic insufficiency originating along the right coronary cusp coaptation line with a posterior directed jet. The transgastric view confirms the eccentric direction of the jet across the face of the valve. AI severity may be difficult to quantify because of the eccentric jet. The vena contracta width is 6.3 millimeters. The jet height to left ventricular outflow ratio is not useful because of the eccentric jet. The pressure half-time is not reliably measured, but there is descending aortic flow reversal, suggesting severe aortic insufficiency. The mechanism in this patient is a tricuspid aortic valve with prolapse of the right coronary cusp and eccentric posterior AI. This is an El-Khoury type 2 example. The aortic annulus is dilated at 2.83 centimeters, but the remaining portions of the aorta are not. Upon inspection of the valve by the surgeon, large fenestrations were found, making the valve unsuitable for repair. A 25 Hancock bioprosthesis was implanted with good effect. Case 6 is a 47-year-old female who presents with acute chest pain. Following investigation, she was taken to the operating room for a surgical procedure. Intraoperative transesophageal echo shows the following. There is presence of a type A aortic dissection involving the ascending aorta and arch with severe central aortic insufficiency. The root dimensions show dilatation of the sinuses, sinotubular junction, and ascending aorta. AI in the setting of dissection can result from different mechanisms, as those outlined here. A indicates the intimal tear dilates the aortic root and aortic valve annulus, causing failure of adequate cusp coaptation and central aortic insufficiency. B indicates an asymmetric intimal tear that depresses one cusp below the coaptation line, resulting in cusp prolapse and eccentric AI. C indicates annular support is disrupted by the tear, resulting in a flail cusp and central AI. D indicates prolapse of the intimal flap through the aortic valve in diastole, which prevents cusp coaptation, resulting in a variable amount of AI. In this case of aortic dissection, the aortic valve is often normal. The complexity of the dissection is reflected by the need to decide the cannula options, presence or absence of circulatory rests, and whether there are re-entry points from the dissection. Ultimately, it's the clinical state of the patient that dictates what procedure needs to be performed. The surgical options may include to replace the ascending aorta, perform a hemiarch or a total arch, use a trifurcated graft, or a frozen elephant trunk. The question arose as to how to cannulate this patient with a BSA of 1.6 and dissections down to her iliacs. The surgeon elected to cannulate the apex of the left ventricle. The cannula was positioned under echo guidance with flow directed preferentially through the aortic valve. In addition to the dissection flap, there was disruption of the non-coronary sinus and the commissure between the right and non-coronary. The aortic valve was normal, and the commissure was glued back to the aortic wall. A 26 mm graft was secured to the sinotubular junction. Post-CPB shows a preserved, well-functioning aortic valve. We will close with case 7, which is a bit of a teaser for the experts in the field. This is a 37-year-old male who presents with shortness of breath, aortic insufficiency, a dilated left ventricle, and comes for an elective cardiac surgery procedure. See if you can figure out the pathology based on this single view. The mid-esophageal long axis view shows a fairly normal aortic root, but significant aortic insufficiency. The aortic valve short axis view clearly shows the pathology as a sinus of Valsalva aneurysm of the non-coronary sinus. Biplane imaging helps you to understand why the long axis view does not show any pathology, as the short axis plane does not cut through the disrupted portion of the sinus. Classically, the sinus of Valsalva aneurysms are described as having a windsock appearance. This is exactly what this patient had. Shown here is the windsock in 3D full volume in the surgeon's orientation. This 3D full volume can also be rotated to view the orifice of the windsock in the non-coronary sinus of Valsalva. The windsock defect of the non-coronary sinus aneurysm is shown in this intraoperative photo. Compare this with the TEE findings. Surgery involved reconstruction of the non-coronary sinus with bovine pericardium, reconstruction of the right atrial wall, and tricuspid valve septal leaflet repair. This took a cross-clamp time of 83 minutes with a total bypass run of 142 minutes. The post-TEE shows no AI or tricuspid regurgitation. In conclusion, aortic insufficiency may result from cusp, root, or aortic disease. AI quantification uses multiple echocardiographic parameters. Surgical options depend on the mechanism of AI. The echocardiographic assessment for valve sparing includes detailed cusp assessment, basic root dimensions, and specific measures. Thank you very much. Any questions?